I welcome all of you, the faculty, delegates, ambassadors, and the speakers for this wonderful international webinar. And I am Dr. T.H. Chandrasekhar, the Governor of American College of Gastroenterology, India region. I bring warm greetings from American College of Gastroenterology and also from the World Gastroenterology Organization as a member of scientific committee and as the professor of Tamil Nadu Dr. M.G.R. Medical University. I convey the regards from the Vice Chancellor, and I am the founder and chief gastroenterologist of Med India Hospital and Academy. This is the fourth series of our international webinar. The first three series saw over 19,000 delegates from all over the world viewed this our webinar, 19,000 delegates. That really inspired us. We started during the period of COVID pandemic. Then why not we continue these webinars? Because it is very useful. As I was telling just little earlier, it is cost effective and we are able to get the best of the people who have done the original work in that particular field. We are able to get them as a speaker. We gave a nice catchy title, name the topic, the world experts are here. And it is now the new Endo GE. GE means gastroenterology webinar series that has become a great news among gastroenterologists of these webinars. We organized 12 webinars starting from April 24 and it went on to March 25 in the third series. Now fourth series is from April 25 to March 26. Our webinar series were inaugurated by Professor Dr. Jonathan Lighton, the President of American College of Gastroenterology. And a webinar witnessed the great the participation of the Nobel Prize winner, Nobel laureate, Professor Dr. Barry Marshall, who is the discoverer of Helicobacter pylori, which revolutionized the management of peptic ulcer and stomach cancer. And that webinar saw the participation of over several thousand delegates from all over the world. That again inspiring to listen to Professor Marshall. That's a lifetime experience to listen to a Nobel laureate. These webinars would not have been possible without the hard work and participation and the inputs given by Dr. Gokul, my colleagues, Dr. Satyamurthy, Rajayogesh, Dr. Prasad, and Trinyana Sambandam. And these webinars have been given the catchy title to attract not only the participant to carry home the various messages, and you just see the stalwarts of various national faculty and international faculty are going to participate. Already some of them have participated, and the very eminent international national faculty. Again, I must thank you that various people have agreed to be the moderators or the leaders in their field in various parts of the country in India, and a panelist from for various sessions. I'm not able to read it one by one because it will consume a lot of time. What I just have done it this time is we have changed the strategy in the webinar 4 series. We have included some of the topics which all the gastroenterologists need to know, like diabetes and gastrointestinal tract, systemic hypertension and portal hypertension, dyslipidemia and fat and liver, pharmacotherapy of obesity, and endoscopy and surgical management of obesity. Now we are coming in August, doctor and law and doctor and ethics, and we'll move on to after that next month doctor and research grants, and further doctor and finance, doctor as an entrepreneur, and research methodology part 1 and part 2, and do we need to do master health checkup in gastroenterology, how to deal about the precancerous lesions in gastroenterology, and February Just the date has been changed 2021-22 live demo workshop on digest. I will welcome all the ambassadors, faculty, speakers for this. And 12th March 12th, the last of the webinar series 4 will be endoscopy versus surgery in gray areas in gastroenterology. And today webinar, we are going to see two very important topics, doctor and law and doctor and ethics. I think this is the form the foundation for anybody's practice. Who should attend? Every doctor should attend. And maybe some of the lawyers who are interested in the medical profession in helping us will also be benefited. Uh, the and the first topic will be by our advocate colleague, Mr. Anand David, advocate sir, and he's a senior partner, AVV partner, and I'll be introducing properly now. And the second speaker will be the Dr. Andrew Storm. Now, this is my duty to introduce the faculty. Advocate Anand David, Bachelor of Law, Counsel for Indian Medical Association, Tamil Nadu, Counsel for PPLS scheme of the IMA Tamil Nadu. That's one of the wonderful scheme the IMA Tamil Nadu has introduced. Counsel for the Tamil Nadu Medical Council, and a former Standing Counsel Tamil Nadu Dr. MGR Medical University, former Standing Counsel the Dental Council of India, former Constitution Committee member CMC Vellore, recipient of IMA Tamil Nadu State Award, and a senior partner of AAV Partners Law Firm, Chennai. So we welcome you, sir. And that will be ably, this talk will be ably moderated. My good friend, Dr. G.N. Ramesh. He is a senior consultant medical gastroenterology, Astor Hospital, Kochi, fellow of Society of GI Endoscopy of India, vice president of Indian Society of Gastroenterology, Kerala chapter, and founder, convener of the Cochin Gut Club. He's got a special interest in IBD and hepatology apart from the therapeutic endoscopy. I have listened to him some of his talks. He's an expert in legal and ethical issues related to the organization. Our second speaker will be joining very soon, so I'll be introducing him again. And he is the therapeutic endoscopy director, endoscopy clinic, Mayo Clinic, Rochester, team leader, endoscopy innovation, and research focus on novel bariatric intervention, non-surgical diabetes treatment, and real-time cancer diagnostic and treatment techniques. Widely, he has got publications and active in clinical trials and recognized innovator in endoscopy technology. He has got several publications to his credit. And another colleague of mine, the senior friend, Dr. Amitabh Chak, would be available. He's traveling. Hopefully, he'll be able to join us. He's the professor of medicine oncology at the Case Western Reserve University School of Medicine, USA, President American Society of GI Endoscopy. That's a very important, very glad to have the President of American Society of GI Endoscopy, and he has got several credit to several publications and several awards to his credit, and he's contributed to Barrett's esophagus patient registry in USA. That's a very big time research work. And we have able eminent surgeon and gastroenterology, a mix of young and middle age and senior surgeon, and Professor Dr. Kapil Neela Megam. He is MSFR, FACS, surgical gastro, hepatobiliary pancreatic, and minimal invasive surgery, and multi-organ transplant, clinical head, and senior consultant, SRM Prime Hospital, Chennai. And Dr. Ravesh Kumar, professor and HOD, Department of Gastroenterology, Usmania Medical College General Hospital, Hyderabad. Dr. Ashish Agarwal, again, young, upcoming gastroenterologist. We have kept the mix of everything, young, old, middle, and senior, so that we'll have a fruitful discussion. Associate professor and faculty in charge, Department of Gastroenterology, All India Institute of Medical Sciences, Jodhpur. This would not have been possible, these webinars, without the participation, active work done by our ambassadors. I could see Dr. Ramesh Kumar from Telangana, Srinivasa Rao, Dr. G.N. Ramesh, just again, hi G.N. Ramesh, and Dr. Praveen Kumar from Kerala, Arvind Gobi from Karnataka, Grish, already logged in, Odisha, and Mahapatra from West Bengal, Ashish Agarwal from Rajasthan, Nirmal Jit from Punjab, again a very active ambassador of our group, and Venkat Iyer, and Lamba, and Jain Ghosh, and Ashish Kumar Jha, Arvind Kumar, Devendra Singh, and we have equally the international ambassadors also. Dr. Vivek Sandeep Chandramouli has already logged in from Malaysia, Sitaram Chaudhary from Nepal, Farooq Ahmad from Bangladesh, and my friends and the students from Nigeria, UAE, Australia, and Sri Lanka, Nepal, and Myanmar Professor Dr. Tantanai. So with this, it is possible for me to do 38 webinars. And today's webinar is going to be very important. Why did I select Dr. G.N. Ramesh? Once he called me to give a talk on ethical practice, and I gave I had to prepare quite a bit. Then he was moderating the session. He was so well versed with the ethical issues and the law. I thought he'll be the fitting person to have you, Ramesh. Ramesh, I'm glad that you could make it in spite of your busy schedule, both in professional and Rotary organization. And first speaker is going to be Anand, Advocate Anand sir, and he is attached to IMA. Since you came little late, I'm just telling you, he is the Indian Medical Association, very senior advocate, very powerful speaker. And with this, I will hand over the mic to you. You can introduce the topic and invite the speaker, and I will start the proceeding, and back to back both the lectures. And after that, we'll take up the questions, and you are going to lead the session of the. Already we have 40 questions lined up. So I request all of us be brief in the question and equally brief in the answer. With this, I'll hand over the mic to my friend Dr. G.N. Ramesh.
Thank you very much, Dr. T.S. Chandrasekhar. I hope I'm audible and visible to you. Thank you very much for this opportunity. And this particular topic is very close to my heart because I've been sort of very interested in this topic. And whatever we say, how much soever we say or talk about this topic, I think you will not be able to do justice in any amount of time that you give to this topic because this is so intricately woven, medical practice and law. And all of us, each one of us, however senior we are, wherever, however high we have reached, we are all susceptible to all these problems, and we need to keep our eyes and ears open and also attend such sessions, try to gain wisdom, try to gain tips from people who know more about this than us. So, Doctor and Law as the first lecture, and we have a very, very senior advocate, a prominent advocate, Anand David, to be talking to us on doctrine law. I know in the time allotted, he may not be able to cover up everything, but I'm sure he is going to actually give us a good brief about what our responsibilities are, what we should be doing, and what we should not be doing. After that, after the second lecture, we'll take up the questions. Over to you, Advocate Anand David. Looking forward to your lecture.
Thank you for the kind words, Doctor. And good evening to everybody, and good morning to Dr. Chandrasekhar, our dynamic chairperson. And thank you for having me here today. So, the topic, as Doctor introduced, we'll be speaking about is doctor and law. Now, if you see about a decade back, doctors were not required to know the intricacies of law. Only a superficial knowledge of the law, which you would have studied in medical college in your curriculum, would suffice for you to practice medicine comfortably. But now, a decade down the line, now due to the phenomenal increase in medical legal litigation and the award amounts also, which have gone up from lakhs, it's gone up to crores now. It's become imperative for all doctors and hospitals to not only know the law superficially, but also know the intricate nature of the issues that may be thrown up on a day-to-day basis. Now, this increase in litigation, phenomenal increase in medical legal litigation, I would say there are basically two major reasons for that. The first one, I would say, is public perception. Now, over the years, public perception against doctors and the health sector per se has changed a lot. The reason why it has changed is because of many things. But initially, what has happened is, you know, in the year 2019, the new Act, Consumer Protection Act, came into play. So when this new act came into play, there were some clauses in that act which were quite disturbing and quite draconian, so due to which the pecuniary jurisdiction of the courts also increased. Like if you make a comparison, earlier doctors were brought under the purview of the Consumer Protection Act way back in 1995 by a case called VP Shanta case by the Supreme Court of India. Then what happened was, as years went by, at that point in time, the Consumer Act was the Act of 1986, which was till 2019. In the 1986 Act, the award amounts that were given at that point in time were, I would say, 5 to 10 lakhs. Even if a 10 lakh award was there, we used to consider it as a very big award which was given by the court. But subsequently, after the advent of the 2019 Consumer Protection Act, things really drastically changed. What happened was there were certain clauses which are included in the act, which necessitated the awards, large amounts of awards to be given, which which became a real issue, which we are facing in today. Then subsequently, what has happened is the second point, the reason why these awards have also increased is the lack of documentation. Earlier, we used to file enough and more documentation before the courts. But now what has happened is the courts, we used to let in evidence as well. But now the courts have uh, been constructed in such a way that they look only at documentation. So I would say, I've heard somebody say that you treat the case sheet before you treat the patient. That is very much true, because without documentation, we will be unable to substantiate any of our points or defenses in court. Now, this has become a vicious cycle, because now what has happened is, because the award amounts are so high, doctors have started asking for more tests. And because of the more tests, the cost of treatment increases, and doctors have also started practicing defensive medicine. So ultimately, it's a very vicious cycle. So it has shaken the very foundation of the healthcare sector. So what can be done by us to preempt these things, to curb litigation, or at least if there is litigation, to ensure that we don't I'm just trying to put on the slides.
Shiva, can you help? Just to have to share.
Yes.
Yeah.
So I've put together about 6 points, which I would call the 6 C's. If taken and followed seriously, we'll be able to curb litigation to a great extent. So the 6 C's are the case sheet, communication, CCTV, consent, composure, and complaint. Now, to start with the case sheet. The case sheet forms an integral part of your documentation. As you all know, there are certain, when the matter comes to court, there are certain areas which glare at us, and in which the doctors get into trouble. Now, I'm going to just point out a few of those which practically I've seen in court. Number one being blanks in the case sheets, and case sheets which are not complete. When I say case sheets which are not complete, what I mean is, when you finish your work in the operation theater and when you come out, sometimes you still haven't completed your case sheet, and still somebody is there writing the case sheet, which is the normal order of the day. because you'll be treating the patient and you have your junior doctor writing the case sheet. But sometimes what happens is in a time of crisis, if there is a, let's say there is a that's a death and there is a mob outside, and suppose somebody gives a police complaint and the police come there and the police ask for the case sheet maybe a couple of hours after the surgery. Now at that time, when the police are asking for the case sheet, you cannot say no, you have to hand over the case sheet. So when a case sheet is given and it is incomplete, and that forms the backbone of any litigation in future throughout. So what happens is you are stuck with an incomplete case sheet, and then when the matter goes to court, then the lawyer for the patient will take a stand saying that this case sheet is written haphazardly and it's not even complete. So what would the doctors would have done in the surgery? So it's very important to make sure that you complete the case sheet before you come out of the theater. Please, if it is possible, have a junior doctor write the case sheet simultaneously so that it is completed by the time you finish the surgery and come out. And the second thing is about case sheets being given to the police. As I said earlier, when somebody comes and the police asks for the case sheet and you part with the case sheet, please take an acknowledgement from the police that the original case sheet is handed over. Because we have seen cases where they come, you hand over the case sheet, and subsequently you don't have the original with you. And when it goes to court, in evidence, you are supposed to submit the originals. In some courts, they verify the originals in evidence. So at that time, you may not have the original. So you need proof to show that you have given the originals to the police. So please take an acknowledgement from the police personnel who come there and ask for the case sheet and to whom it is handed over. And then comes the 72-hour time period within which you should give the case sheet. Now, when I say 72 hours, what I mean is in the 2002 ethics rules, what it says is that if somebody makes a request for giving the handing over the case sheet by the hospital or the discharge summary or any of your other medical records, if the patient or the attender or anybody authorized by the patients makes such a written request, the hospital or the doctor is supposed to hand over the case sheets within 72 hours from the time of asking. So if, in fact, in many cases where, the patient has asked for the case sheets, and what the hospital does is they get jittery at that time and they don't give the case sheets and they give only what is called the case summary. Now, in a case which went to court, such a summary was given, and though we succeeded in the case on merits, the court had held the hospital to be negligent because the case sheet was not given. Because case sheet is the all-encompassing document which has everything in it. So please make sure that when a request is made, hand over the case sheet. You don't have to give the original, a photocopy is fine. Hand over the case sheet, or if they ask for the discharge summary or they ask for any other medical records, scanned reports, please hand it over and get an acknowledgement from the patient or the authorized attender. Then moving on to postmortems. Now, if let's say if there is an death of a patient and a postmortem is suggested by the hospital and the relatives refuse the postmortem, please make sure you make an endorsement in the case sheet that you had suggested for postmortem and the relatives had refused. The reason I say this is many a time we suggest for a postmortem and they refuse and there is no endorsement in the case sheet. Tomorrow, the same patient, the same attenders, the kith and kin of the patient who has passed away will make an allegation in court saying that we wanted postmortem, but the hospital refused. So these are sticky situations which can be avoided if we take these precautions. And then next, coming to an important aspect again of records, which is the discharge summary. Now, discharge summaries, please ensure that you give only one discharge summary. I know this might be a bit out of place when I say one discharge summary. You always give one discharge summary. The reason I say this is, again, we had a case in court where a patient had come with liver failure, and the patient had ultimately succumbed to the disease. But in the case sheet, it was written that he was a chronic smoker for 13 years. Now, after his passing away, the kith and kin sent it for insurance claim. Now, the insurance company initially they told the relatives that, we could have given this if it was, we could have sanctioned the insurance if it was 2 years, but not 13 years. I don't know why they said that, but they said that. So the patient comes back, the attenders come back to the hospital. The hospital authorities are very well known to the attenders. So the attender makes a request saying, if you can only change the discharge summary one line there and say 2 years instead of 13 years, we'll get this insurance. The insurance amount is about 1 crore of rupees, and that will really help the family. So the hospital, being kind-hearted, and since the patient is a known patient, they change that and say 2 years. So when that goes, unfortunately, the insurance company rejects that claim. And when they reject the claim, the attenders take it to court. So when the matter goes to court, it's an open and shut case for the insurance company, because what happened was they filed both the discharge summaries in court, and they said, how is it possible to have two discharge summaries, and in one discharge summary there is tampering, and they have changed the wordings in the second discharge summary. So there, naturally the hospital and the doctor were held negligent. So it is very important that, however well you know the patient, please do not tamper with the discharge summary. Let there be only one discharge summary to be given to the patient. And another aspect about records is retaining certain copies of your prescription and OP records, and even your referral letter for that matter. Because in many areas, many matters, what has happened is when you give a referral letter referring the patient to a higher center, we don't have a copy. You give the letter to them. So tomorrow, when they go to court, when the matter ends up in court, unfortunately, if the patient comes and says that, they didn't give any referral letter, no discharge summary was given. They just sent us off, and we had to make arrangements for our own ambulance. And we went there. And in the subsequent hospital, the doctors had no idea about what earlier treatment we had. And these are practical problems which we face. So I would only request you to please have a copy of the referral letter and your prescriptions, so that it'll be of use at a later stage. Then moving on to the next C, which is communication. Now, as far as communication is concerned, empathetic communication is required. And you all know, in today's world, when there is Google, everybody, goes to the internet, they Google their ailments and come to you, and most of the times, they cross-examine the doctor. Believe me, we have that in our profession as well. When clients come, they've Googled a lot about the case and come and ask us a lot of questions. Be patient with them, and be empathetic. And another aspect, as far as communication is concerned, is when there is a crisis, the first responders to the crisis are normally your staff. So if your staff are trained in conflict resolution, that will take you a long way in avoiding the crisis escalating into a litigation, or even a legal notice for that matter. Because it is also advisable in a time of crisis for the senior doctor, or the doctor who had conducted the surgery, not to go and speak to the patient right away, because the tempers might be high at that time. So if your PRO or your manager of the hospital or somebody can go and assuage them, who are trained in conflict resolution, and then bring down the tempers, and then the operating surgeon can step in and apprise the attenders appropriately. So that is as far as communication is concerned. Then CCTV. CCTV, I'm sure you're all, most of the clinics, hospitals nowadays have CCTVs and microphones. And it's one of a very integral part of evidence which we file in court. So I would only say, please ensure that your CCTVs are functioning, and the footage doesn't get overwritten, because in many a time we find that if there is a crisis on that particular day, that footage may not be available because subsequently it might get overwritten. So if there is an untoward incident in the hospital or the clinic, please make sure that you take the footage in a pen drive and store it so that you can use it at a later date. And I'm reminded of a case where in Chennai, we had a case where there was a doctor who was running a clinic, and he was not in very good terms with a local politician. There was some issue with parking of the cars in the road opposite his clinic. So what happened was that politician used to send some fake patients to the clinic, and every time these fake patients come, they used to cause a ruckus. And one such time, uh, father and daughter, or rather they called themselves father and daughter, they come into the doctor's consultation room. Suddenly that both run out, saying that the doctor has misbehaved with the daughter, and there are 10 people waiting outside. They rush into the clinic, start breaking stuff and threatening the doctor, and they go and give a police complaint saying that doctor has misbehaved with the daughter. Luckily for him, he had a camera right above his head with a microphone. So right from the inception, when the couple walked in, everything was recorded. So we were able to put it on a pen drive, go and give it to the police. And the police not only closed the case, an FIR was filed against the father-daughter duo. So it becomes very important for us to have CCTV which is functioning. And also, if you can have placards in your clinics and hospitals at vantage points saying that this place is under CCTV surveillance, that itself would be a deterrent for any escalation of violence. And the next C is consent. Now, I don't have to tell you how important consent is. So, consent is you cannot carry out any procedure with an informed consent, not only a ordinary, it should be an informed consent. And the most of the times, some discrepancies which I find in consents are that, let's say if there are two procedures which you have done, and one is a minor procedure. Sometimes what happens is the minor procedure is not mentioned in the consent. For example, a hysterectomy and an oophorectomy. And hysterectomy is mentioned and oophorectomy is not mentioned. So this becomes a very valid issue in court, where they say that you have taken consent only for an hysterectomy, but you out of your own volition have done the oophorectomy. Gone are the days when 20 years back you used to do it and patient used to thank you saying that you've taken a call on their behalf. Nowadays believe me, things have changed. They are looking for every small loophole in your documentation. In fact, when I argue in court also, I keep telling the judges, it's very easy for us to stand here today and go line by line in a case sheet, but you imagine what transpires in the operation theater. Will the surgeon be looking at the case sheet word by word and writing it down, or would he be concentrating on the patient and operating on him? So it is very unfair for us to stand here and go line by line on a case sheet. But that's the order of the day today. So we need to change our ways as we progress, as the law also progresses. So then comes the consent. It can be a written consent or a printed consent. And in fact, there was a recent judgment of the National Consumer Commission, which said printed consents were not consents are not acceptable in law, and it should be only be written. But luckily, the Supreme Court stayed this judgment. So now printed consents are fine, and written consents are also fine. And especially if it is an illiterate patient, you might be taking a thumb imprint of the illiterate patient. And when you do that, I would say kindly ask the attender to write down the consent and then take the thumb imprint and ask the attender who is written down to sign as a witness to that consent form. The reason I say this is sometimes what happens is they produce an illiterate his thumb imprint on a blank sheet of paper, they have filled it up subsequently. So that's that a long way in preventing all these things. And next comes composure. Composure is at a time of crisis. please be composed. Do not panic. Call your peers, if you're part of any association, Indian Medical Association, any other associations, call them for your support, because in India, as you all know, safety in numbers matters, especially if you're going before an authority or a police station or somewhere. It's always better to a group of doctors to go there rather than one or two doctors. So, and also take your lawyer with you when you go to the police station. And when you receive if and when you receive a summon from the police station or a oral request, sometimes it's only an oral phone call, a request which comes saying, can you please come to the police station? Let not the doctor from the hospital go to the station immediately. Please send your lawyer or your manager or a PRO along with a copy of the case sheet to the police station. At least I've seen 75% of the time it gets resolved then and there, if the manager or the PRO or somebody unconnected with the case goes. The minute the doctor goes, things escalate there. And sometimes the police say they make the doctor sit there for hours together, and they might even arrest the doctor. So please ensure that the doctor does not go at the first instance, and take a lawyer who is well versed in medical legal laws. Now, the reason I say a person who's well versed in medical legal laws is, just like in medicine, we have specialists in various fields. Now, as you all know, medical legal laws are not, there is no particular act that governs medical legal laws. It's only precedents from courts. So the person who accompanies the doctor has to be well versed with the latest precedent, the latest circulars that have been issued by the police, and so on and so forth. So if you take your lawyer to the authority, it will be useful to protect yourselves as well. And the last C is the complaint. Now, when I say complaint, I mean a police complaint. Now, what happens is, I don't know how many of you are aware of this, that there is a legislation to protect doctors and hospitals. Now, this Tamil Nadu Medicare Service Persons and Medical Service Institutions Act, which is popularly known as Act 48 of 2008, was promulgated many years ago. But unfortunately, very, very minuscule number of doctors and hospitals make use of this. Now, who can take recourse under the protection under this act? Any registered medical practitioner, nurse, medical students, or paramedical workers. Now, let us say there is a you get into there is a commotion caused by the attenders of a patient in the hospital, and normally there'll be a busybody there from the attenders who may not even be related to the patients. He is the one who will start instigating, and there'll be a mob there. Now, for the first time, the legislature has enacted an act where you can even sue the person who is instigating. So anybody who instigates intimidation, endangering, damage to property, all can be sued in this. And the punishment is draconian. It's 3 years to 10 years imprisonment with fine. So it is a very, very effective act to take recourse to when there is violence in the hospital. And even a small WhatsApp message which threatens the doctor is considered as intimidation, and a complaint should be given. Now, the reason I'm impressing on you to give, I know you're all busy, hospitals are all busy, nobody wants to prosecute their patient. That's the last thing on our mind. But the reason I say this is, let's assume that there is violence, or there's some kind of, no, not violence, just intimidation to the doctor. Now, if you give a police complaint under this act and an FIR is registered, what happens is, tomorrow the patient has 2 years' time to go before the consumer court and file a case against you for compensation. So let's say he goes to court 1 year down the line, files a case for 1 crore compensation against the hospital. At that time, this FIR which you have filed against the patient will be immensely useful to use it as a tool to bargain and make him either withdraw the complaint or bring the compensation level down. So that also changes the minds of the judges at the time of arguments, because when you say that this is the same person who came and broke my hospital and threatened my doctors, this is the CCTV footage, this is available. The minute CCTV footage is shown in court, many judges, immediately their sympathy moves away from the patient to the hospital. So this is a very effective act. So I would only request you to kindly take recourse to this act and ensure that, complaint is given and an FIR is filed. Now, moving on to the next area of preventing litigation is your legal notice. Now, when you receive a legal notice, I hope none of you receive a legal notice, but if it happens ever, that is the inception of the litigation. Now, we need to be very careful at this stage as to what we reply to the legal notice. The reply, first you have to take you I would advise you to take the legal notice and give it to your lawyer with a detailed note on what has transpired, along with a copy of the case sheet, your opinions which you have sought from other specialists, discharge summary, your temperature charts, and everything. And make sure that when the notice is drafted, there should not be anything contrary between the case sheet and the temperature charts and the other nurses' records. Sometimes there are, there is a dosage will be mentioned differently here and there. So you need to go very carefully through that and make sure there are nothing contrary is mentioned in your reply. And let the reply be concise and brief. And do not reveal all your defenses at the inception stage itself. The reason I say that is, initially, if there is a legal notice and the lawyer for the patient makes a mistake, there is a technical error in that. Please don't correct him. Sometimes what happens is we immediately write and say, no, no, it is not that, that is wrong, and this is the correct provision of law and all that. Don't do that. Sometimes what happens is the limitation time mandated under the Consumer Protection Act to file a case against a doctor is 2 years. Sometimes these notices are issued 4 or 5 years later. And when they go to court to file a complaint, they need to file what is called an application to condone the delay in filing the complaint, because there is a delay in filing the complaint. So if you remind them at this stage, saying that, please, you are delayed in issuing this notice, then what they'll do is they know that they have to file that application in court. So they'll correct that and they'll file it. So please don't get into the technical aspects. If there is a mistake, let the mistake lie. It'll help you at a later stage. And another very important aspect of a reply to a legal notice is absolutely no personal allegations against the lawyer who has issued it. The reason I say this is I've seen many notices, reply notices issued by doctors through their lawyer. In fact, one doctor had written saying that, I have a reputation for over 30 years, an impeccable reputation, and you have issued such a notice to me. What kind of a lawyer are you? Do you know the law? And things like that. So what happened was, when this matter went to court, in fact, we had 90%, we have succeeded on all points on merits. But when it came to this particular aspect, when the opponent lawyer showed this reply notice, the entire complexion of the case changed. The judge's sympathy just moved from there, and we had a really, really tough time, defending that case. So please ensure that there are nothing personal in the notice. Now, coming to court mediation, what is court mediation? I'm sure that most of you would have heard this term, out of court settlements, which is that when you receive a notice, or when the patient or the attenders come and speak to you and say, look here, that this is the mistake the hospital has done. So why don't you compensate me by giving me 5 lakhs or 10 lakhs, and the hospital or the doctor also, they take a call. They think, okay, fine, let's, there is seems to be a mistake. So let's settle this matter. So they bargain, and instead of 10 lakhs, 2 lakhs is given, and the matter is settled. Now, what we need to understand is, by even after taking that 2 lakhs, this same patient can go to court and file a case against you for 50 lakhs. So please do not do any out of court settlements. Under the new Consumer Protection Act, there is a particular clause where it uses mediation through the court to settle these matters. For example, if a matter is filed in court and there is a a claim of 25 lakhs is made. Now we know that there is a mistake. There is a mistake in the documentation by the hospital. Hospital wants to settle. So what we do is we request the court to send it for mediation. So the court sends it for mediation. So both parties sit there and mediate. They arrive at a figure. Let's say it's 5 lakhs. It's arrived at 5 lakhs. Then the court passes a detailed order saying that the matter has been mediated. The matter has been settled at 5 lakhs. 5 lakhs has been paid by the hospital on humanitarian grounds, and all allegations of medical negligence are withdrawn against the hospital. So not only all allegations are withdrawn, but also this is a non-appealable order. That is, once the order is signed by the judge, he can't appeal to the higher forum as well. So the order attains finality at that stage. So please use court mediation effectively. This is one of the plus points in the new Consumer Protection Act. And that brings us to the end of the session, and I'll be glad to take any questions. Thank you.
Thank you very much, Advocate Anand David. I think the format of this session is that we go to the next talk, and then after that we have a common question answer session. So I hand it over back to Dr. T.S. Chandrasekhar. Thank you very much for that lovely talk.
Ramesh,
Thank
you would agree with me that he started with the 6 C's: consent, communications, and that really liked it very much. I think he has got a lot more in store to tell us in the question answer session. And we'll move on to the second session. I just want to briefly share the slides of Dr. Andrew Storm. I'll invite Dr. Andrew Storm to give the talk on ethics in GI practice, that is endoscopy practice. I've just introduced. Shiva, can you just send the slides of, okay. Before he comes to the, uh, comes on the screen to give a talk, I just want to introduce Dr. Andrew Strong. I just had an interaction with him during the dry run session. He is so fascinated and he's got a passion for ethics and GI practice. And he is one of the very leading members in American College of Gastroenterology and American Society of GI Endoscopy. He's got several publications to his credit, and his H index also very high. He is very much interested in innovations in endoscopy. He works for the Mayo Clinic at Rochester, and he is a well-known person to deal with doctor and ethics. May I request Dr. Andrew Storm to start the topic. The ethical practice, there are so many questions in endoscopy. Can I just I will close this. Okay, right now. And whether we can use the accessories, reusable accessories or one-time accessories, and how much are concerned to be taken during doing the procedure with a lot of complications. Like say that pancreatitis related to ERCP has got a highest level of the legal implications. We have that. How much to explain to the patient? If the complication occurs, who has to pay for that? Whether a doctor or the insurance company will pay for it, and how much to reveal to the patient. Some patient may not like to be revealed everything at the same time. If you don't disclose it, you are in trouble because of the not disclosing so many things in the ethical point of view. And the cleaning, disinfection aspects, and how much the patient is aware of this. All these things may be discussed. He has got a talk. He told me that he would need at least 40 minutes. I requested him to bring it down to 30 minutes so that we'll have more coverage during the question answer session. Now, Dr. Andrew Stam to start the lecture. I invite him, Dr. Andrew Stam. Please, can you unmute yourself and
Thank you, and thanks for the reminder on the microphone. Thank you, Dr. Chandrasekhar, for the very kind invitation to speak to everyone today. And it's a pleasure and an honor to be with you all to follow that wonderful lecture doctor and law. I think it makes all of us nervous, no matter where we practice, no matter who we are. We're here to help people. We're here to improve the health of people, which is why we've chosen this field. And so I think one of the best protections, like with anything, is a good defense. And I'm glad we have lawyers like we learned from today who are on our side, who are here to help us continue to do our work and to be able to do that important work. So one of the things I think that helps avoid ever having to meet with a lawyer, again, lawyers are wonderful when they're helping you. One of the best ways to defend yourself is to inform your patients to have proper consent, and that's something we'll focus on today. I've been lucky to be a part of the guideline writing committee for the American Society for Gastrointestinal Endoscopy. And we have a consent guideline, a document that helps guide us in endoscopy. All of us who do endoscopy and endoscopic procedures helps guide us in terms of best practice for how we consent patients. I will say, while the law is different in the United States and in India, there are subtle differences, sometimes big differences between the practice of law and medical legal law in particular. One thing that is common to all of us across the board is the ethics of medicine. I think this is something that a lot of us can agree on. Again, no matter where we practice, whether we're in a rural community setting or in a large city practice.
Andrew,
So,
may I request you to convert to slide mode? You are in a presentation mode.
does that look better?
Yeah, this is fantastic.
Okay, good. We'll go with it this way. So these are my disclosures. We won't talk about anything off label, although we have different systems for that. The learning objectives from my talk today, I'd like to introduce the core principles of medical ethics. Again, I think these are common to all of our cultures, and it's common across nations. We'll examine these principles through a couple of case examples. So I'm a therapeutic endoscopist. I really like interventional endoscopy, and I'll use case examples for how these principles apply to my practice and how I'm trying to help move our field forward with our team here. And then we'll talk through a couple of ethical dilemmas, possible solutions, and have a wonderful question and answer session, as was mentioned previously at the end. So why talk about medical ethics? Conflicts exist in medicine. We all need to have a framework for resolving conflicts that's applicable and acceptable as possible to our patients, to our practice, to the team that we work with in the hospital. That said, everyone's framework is going to be a little bit different. So faith, society, religion, resource, ethics will vary slightly between families. Here in the United States, we have a very individualistic approach to ethics where patient autonomy is prime, number one, two, and three. And I think there would be some cultural differences. Some of my best friends here in the States grew up in India, and I know there will be some cultural differences in the way that I would speak to a patient as opposed to speaking with their family, like might be done in other cultures. There's a heavy reliance on the individual in the United States. So again, even the ethics will vary slightly between nations. But again, I would argue that in general, medical ethics are a constant across all borders and boundaries. So this is why we talk about it. I actually don't know the school system in India, but in the United States, we have kindergarten, which is your first time going to school. My youngest, who's a 6-year-old, just finished kindergarten, her first year of school. And there's a poem that's very popular in a lot of classrooms where they say, all that you really needed to learn, you learned in kindergarten. This is the grade where you learn how to share and you learn how to treat other people. There's not a lot of math and reading at that age, but it's mostly learning how to socialize and how to be a good citizen in your culture. And I think there's a lot of truth in that poem that even in medical ethics, a lot of the things we needed to learn, we learned from our mothers, we learned early in life. And I'll try to show some examples of that. So these are the 4 core principles, again, multicultural, 4 core principles for medical ethics: autonomy, is the respect for patient self-determination, that I get to choose what happens to me. I can receive a professional opinion from Dr. TSC on how we should manage this colon polyp, but ultimately it's my choice for how we move forward. Beneficence is the duty to promote well-being. That's an oath we all take entering the medical profession, to promote well-being and help people be better and do better. Non-maleficence is that do no harm. So first do no harm clause that's in the medical code of ethics. And then finally, justice, which is challenging, very challenging here in the United States, I think challenging throughout the world, is how do we fairly distribute healthcare resources? I think this is something we struggle with in our own country every day. How do we fairly distribute the resources that we have to help people achieve health? The cornerstone for an ethical practice, and I think it's especially true in a procedural field like gastroenterology, is the informed consent. And so this is also in legal doctrine a great way to preempt a lot of lawsuits, to preempt a lot of concern on your patient's behalf. If you practice perfect informed consent, I can almost promise you, and there's good data to support this, that you are very unlikely to ever be sued by a patient. So this guideline we published in 2022. This is a guideline available online, free and open access. This is the way we approach with our society, the American Society for Gastrointestinal Endoscopy, consent. It includes an example of a consent form, so it's something that any group could copy and use in their own practice as a templated consent form. I would definitely recommend working with your local expertise, so a potentially legal counsel, your hospital or practice leadership, to ensure that the form covers everything they think should be covered in a consent form. But then that leads us to what is informed consent. And when I talk to my trainees, my fellows and residents who are in their medical training, when I ask what is consent, they say, well, it's a form that you sign. It's a piece of paper that a patient signs so that we can go ahead with the procedure. And that's not what informed consent is. It's much more than a form. It's much more than a signature. Informed consent is truly consent that is a voluntary agreement from a patient with the capacity, so they're mentally able to make an informed choice between a proposed action and either doing nothing or doing some other action. Ensuring that the person is informed is our responsibility as physicians. So if I'm doing the procedure, I need to ensure that that patient understands the procedure, why we're offering it, and the alternatives to that procedure as a necessary part of the informed consent. From there, the signature, that legal document that the patient will sign, is just purely that. It's a legal notation that we have completed the informed consent. But again, to me, the best way to head off a lawsuit and to avoid an unhappy patient, which is never our goal, the best way to do that is to ensure that a patient is truly informed, that they have had an opportunity to ask questions, they understand what the issue is, what the procedure will be, and why we're doing it, and what those alternatives would be, including what would happen if we did not do the procedure. Those are the most important ways to head off lawsuits, in my opinion, in my experience in gastrointestinal endoscopy. Here in the United States, we have the reasonable patient standard, which has become our ideal. This is where we, as a medical team, we must guarantee that we have provided information that a reasonable layperson would consider material and significant. So what you would want to know as a layperson in consenting to a proposed procedure. And if we have achieved that, legally, we are very well covered. If we've explained to the level of a layperson through the informed consent process, that really is informed consent, not just the form itself. So informed consent in endoscopy, outlined in our guideline, includes a review of the relevant medical conditions and results. It includes a description of the procedure, including any diagnostic or therapeutic interventions that are likely to occur. So if I'm going to do a colonoscopy, I always talk about polypectomy, even if it's a simple screening colonoscopy. I talk about the things that we're likely to do. If it's a patient with dysphagia, I'll talk about the risks and benefits to dilation, esophageal biopsy. Potential common and serious risks and adverse events associated with the procedure. Even though perforation is incredibly rare with an upper endoscopy, diagnostic upper endoscopy, I'll still mention it as a potential risk to the procedure because it's very serious, as we all know, when that happens. And then we'll talk about a discussion of the alternatives to the procedure, including the option to do nothing and the risks associated with doing nothing in those situations. And then we'll talk about the potential need if we're doing a monitored anesthesia care or a sedation or an awake procedure. I'll talk about the potential need to intubate, to resuscitate, to give blood transfusion, the potential need for hospitalization. If those things are done, the patient understands, I think they're much less likely to come back to you later with concerns about the care that they received. Again, we want to document the patient's preference in this document. It can be very protective if it ever comes to being in a court of law, which of course we would all rather avoid. So autonomy is our first case example. This is respect for patient self-determination. And I use this case as an example. Since we're all in gastroenterology, I'll use GI cases. I had a patient recently, lovely guy. He's allowed me to share his story with everyone. 45-year-old man. He was in healthcare himself. Metastatic neuroendocrine tumor that caused bilateral biliary obstruction and recurrent cholangitis. To Dr. Chandrasekhar's point, he actually had pancreatitis during his first ERCP, which was done elsewhere. And I think it's really a shame that we still have to tell patients that in 5 to sometimes 10% of cases, they may experience pancreatitis. ERCP, we have a lot of innovation left to do to make it a safer and better procedure. Always have to tell patients about the risk of pancreatitis in that situation. But he had an indwelling percutaneous drain that was placed at another institution. And this meant he couldn't swim. And all he wanted in life was to go swimming with his children. He knew that his cancer would never be curable at this stage. And he had had previous metal stenting in the biliary tree. But again, he was told, you'll never swim again. You have this percutaneous drain. It keeps falling out. We're placing new drains. There's nothing you can do. He came and asked, from a patient autonomy perspective, I'm going to pull this drain out. I don't want to have it. Can you give me some other option that's an internal drainage paradigm? And so he said, all I want is to go swimming with my kids, respecting his autonomy rather than the advice of another even medical center. We proceeded with an option that's off-label, but what's called an EUS hepaticogastrostomy. And the goal here was to provide drainage to the blocked portion of his liver. You can see here on the screen right, the stomach is dilated. It lies right next to the left lobe of the liver. Here you can see his right percutaneous drain is managing and draining the right side of the liver well enough, but we were able to stent that side through a traditional ERCP route. He has surgically altered anatomy at this point, but you can see here we've accessed and we're draining that side. And here we're using endoscopic ultrasound to access the left side of the liver. So again, these are wonderful procedures. We don't have a lot of devices yet to perform these procedures, so we're using all of our devices off-label for a lot of these things. But here we've punctured into the left side of the liver using a large caliber FNA needle, and that gives us access into the left side of the liver, allows us to place a wire over which we can work to dilate and place a stent. So we'll jump ahead in our video here. We've used a cystotome, a cutting cystotome, and here a balloon dilation to access that duct in the left side of the liver. And then through that channel, that fistula we've created, we deploy a covered metal stent. And this allows us to drain that left side of the liver. And so some of our hepatologists here who deal with a lot of cholangiocarcinoma, Dr. Patrick Kamath, one in particular, who I often work with, this procedure is wonderful to them and their patients. This allows us to drain parts of the liver internally that would have required percutaneous drainage. And so, again, respecting his autonomy led to a risky but ultimately very successful procedure. And my patient sent me this video, which he wanted me to share with everyone. So this is him just after our procedure. He'd had the percutaneous drains removed, and he was able to go swimming with his family. So here he's overseas. in Europe, and he was able to go swimming with his family. I can't tell you, I couldn't stop smiling for days after seeing this, after he sent me that very kind gift. The next principle that we'll talk through as a case is beneficence. That's the duty to promote well-being. Here, I consider this one of those kindergarten lessons that we all probably learned from our mothers, which is that if you open the door, you should close the door. So don't leave the door open. The EDGE procedure, as many of you know, is a procedure where we can access, and we see so much obesity in the United States that's being treated with surgery. Roux-en-Y gastric bypass is a life-saving procedure for many patients with severe obesity. But it leaves us as gastroenterologists stuck when it comes time to do an ERCP. Again, patients generally do not prefer a percutaneous alternative for ERCP. And so this procedure was developed to allow us to bridge using a lumen-opposing metal stent. And you guys have wonderful options for lumen-opposing metal stents that we don't have in the US. We're limited to the Axios stent. But it does the job very nicely, allows us to bridge from the gastric pouch into the excluded stomach and then to perform a standard ERCP through that route. And so this is a procedure that, again, in 5 minutes, we can reverse this maximally invasive weight loss surgery and help someone get their ERCP done. The problem is when that ERCP is done, how do we help that patient back to where they were, which was in a place where they were losing weight? I've had patients regain 50, 100 pounds, 30, 60 kilograms because of the fistula that I've created with this stent. And so I think it's important that we provide the service. If we're going to reverse this maximally invasive surgery, I think we also need to consider closing the door if we've opened it. So here we're using a novel device that we helped develop with Apollo Endosurgery. Here you can see I've removed the Axios stent and we have this fistula still into the remnant stomach. I use a very high wattage, 100 watt argon plasma coagulation, or APC, and we'll treat this fistula. It's also a great way if you're treating a patient with a PEG fistula or any other fistula to manage that. Here you can see we're using the X-Tack device, which is a tack and suture device. These little corkscrews are sort of like wood screws that drill into the tissue. They have a suture through them, and it allows us to cinch together or pull together a fistula opening. And here we're going to use all 4 of those tacks with a suture. Here we're pulling the suture tight and we cinch that suture. And that allows us to close this door. It allows us to repair that fistula. I talk about the APC to my patients as sort of like glue to allow the tissue to heal together. And then you can see here on initial endoscopy, totally healed. There's no flow of contrast through that fistula. And then I always have patients come back in a month. They'll do an upper GI series, which shows that the fistula is still closed. So wonderful outcome for this patient. That's someone who's not then going to go regain all of their weight. I feel that we've done right by the patient. We've certainly helped them maintain their health, which is one of our core principles in a medically ethical practice. The next core principle we'll move through quickly is non-maleficence, which is to say, do no harm. This patient came, he's a 45-year-old man, intermittent GI bleeding and melena. He'd had 4 previous upper endoscopies, had blood in his stomach whenever we looked, but had no source of bleeding. So something we see in gastroenterology a lot, this overt, but unfortunately non-diagnosed source of GI bleeding. He says, why can't you guys find this source? You're supposed to be good at this endoscopy. And the fact of the matter is no procedure is without risk. Every endoscopy that we perform for him comes with some risk of damage, of bleeding, of aspiration, or other complications related to the anesthesia. And I have to point out that, as we all know who do ERCP, diagnostic ERCP is on the way out. We try to never perform diagnostic ERCP. As TSC, Dr. TSC had mentioned, ERCP is a risky procedure. And so if you can avoid it, if you can perform endoscopic ultrasound, if you can perform CT scan or MRCP, MRI, as an alternative to diagnose issues before doing an ERCP for therapy, that's the best way to go. My goal, my hope is that in the future, someday, we are no longer performing diagnostic EGD. We're only performing therapeutic EGD. That will avoid a lot of morbidity and risk for patients, a lot of cost in our healthcare system as well. So if we need to do away with this low yield, costly, risky diagnostic EGD for this gentleman who clearly has gastric bleeding and we just can't find the source, it's never active when we go in, what tools might we have? And this is a very interesting technology. I think there will be multiple companies available to you, your colleagues, certainly multiple coming to the US. This was the first to be FDA approved based on a clinical trial that we led here at Mayo Clinic. Here we're connecting a capsule. So it's like a video capsule, but there's no video component. It has a little photo sensor built in. And this photo sensor detects active bleeding, so bright red blood. And so for this patient, we can actually have him swallow this capsule at the time of suspected bleeding and say, yes, there is active red blood in the stomach, or no, there's nothing active now. And so he actually had multiple of these capsules over time. And eventually we caught a time where the bleeding was active. We were able to find the source. He had a Dulafoy lesion, which is why we couldn't find it when it wasn't active. So normal mucosa with an aberrant vessel underneath. And that allowed us to find and move forward for this patient. The PillSense device, wonderful performance characteristics, highly sensitive, 93%, 91% specific, negative and positive predictive value, very high. So this is much better than NG tube lavage or other things for detecting bleeding. I think this will allow us to make some headway on that do no harm or patient beneficence aspect of our practices in that medical, ethically medical practice. So lastly, justice. So the fair distribution of healthcare resources is a challenge for all of us, no matter where we practice. We don't get to make a lot of decisions, especially in the United States, about who gets covered for what procedures. And unfortunately, we're in a system where, maybe fortunately, where cash pay is not a big part of our practices. So it's really it's a place where people need to have insurance, and insurance companies, private insurance companies, actually determine what patients are allowed to have access to. So justice is something we continue to struggle with in our system. The obesity epidemic, as I mentioned earlier, is a big issue in the United States. I know it's becoming an issue very much so worldwide, but nearly a third of the U.S. is clinically obese, morbidly obese. There's a disproportionate effect on minorities. We know that our African American citizens, Hispanic citizens will actually have worse outcomes because of this. They'll have much worse health outcomes from a cardiovascular, even COVID-19 mortality, metabolic syndrome, cancer outcomes, psychiatric illness, all of this associated with this obesity epidemic. And so this is a health crisis we have to address. This is one of my grandfathers, who is a primary care physician in rural Pennsylvania, and he was giving this first polio vaccine in his community. And that was a time in our country where we saw the life expectancy improving dramatically over time. So there were new vaccines like the polio vaccine. The public health system was wonderful, really helping people live longer. And unfortunately, I think we're seeing a signal where because of obesity, I think that the life expectancy in the United States and many countries across the world is going to drop. And so pediatric obesity, my own children's cohort, their classmates at school, we're seeing that pediatric obesity has tripled in our country in the last 4 decades. It's the #1 pediatric nutritional disorder worldwide. It used to be starvation and vitamin deficiencies, but it's now obesity, which is very interesting. And here at Mayo Clinic, we're actually seeing diseases that my grandfather never would have anticipated. He would never believe that we're doing liver transplant for children with liver failure because of fatty liver disease. It's absolutely incredible. We're treating sleep apnea because of obesity in children, things that didn't exist in his generation and his time. And so we need to have tools. This is something we're seeing come out in GI. And I know this is becoming an increasingly used tool in India as well. We need something between surgery and medicines that can help our patients achieve the weight loss they need to be healthy. And so we're working through the justice aspect to provide these endoscopic procedures as a gap in the risk and efficacy spectrum. This will allow us to offer these procedures, weight loss procedures and metabolic procedures for diabetes to patients who need to lose weight to be healthy. Our goal always to lose 10% or more of someone's weight. That will help them live longer. That's well documented. Lots of data supporting that liver disease will improve, life expectancy will improve with at least a 10% total body weight loss. Definitely something we're seeing with these procedures. This was one of my patients. She was 38. Her BMI was 38. She had infertility issues, really wanted to have a child of her own. She was averse to having a surgical bariatric procedure, but she was willing to consider an endoscopic option. And unfortunately, her insurance company said, we won't cover the endoscopic options. They're still considered investigational. They actually asked her to have, they said she should pay out of pocket for this procedure so that she has what's called skin in the game or buy-in to her procedure. They said, if for obesity, you need to pay. And unfortunately, that was their final answer. So she did pay. And again, I think that's a poor example, a bad example of justice in our medical system. But she underwent the gastric endoscopic sleeve gastroplasty, wonderful procedure whereby the stomach is folded in upon itself, allows us to create a sleeve configuration all through the mouth with very little risk to patients. Weight loss data is wonderful. This is one of our meta-analyses here from Mayo Clinic with my colleague Baram Abadea. And we can see that total body weight loss across many centers in the US and beyond was about 18 to 20%. So wonderful weight loss. We then followed up. I was so angry by her insurance company that we followed up with the insurance company and asked them to take a careful look at our data. We showed that skin in the game or having financial buy-in to weight loss is not helpful. It makes no difference. And in fact, our patients who had the procedure covered for free, either through a clinical trial or by their more generous insurance company, they actually lost more weight on average. They were doing better. And there was even a trend towards improved outcomes for those patients who had it covered through their healthcare system. And so this has been documented in bariatric surgery for decades. Our societies should not require skin in the game or a cash pay option if, and now that we acknowledge obesity is absolutely a medical disease like cancer, it's a lifelong battle. It's something where patients are going to need to have the support of our healthcare system in order to manage that obesity and avoid bad healthcare outcomes in the long term. So we all need to consider medical ethics as we look to our future. I'm really excited about some of these procedures that I presented today, which I think represent some of the future big winner procedures in our field. In conclusion, I'll say that we all must continue to focus our field on the core principles of an ethical practice that includes patient autonomy, acknowledging that that's more important in the United States than in some other cultures, beneficence, helping patients do well, non-maleficence, do no harm, and justice, equitable distribution of healthcare resources across our population. Data transparency, developing standards of care, ensuring equitable access for our patients is key. And of course, all of this is getting, tossed up and messed up by artificial intelligence, which I think if we use it correctly will actually help disseminate healthcare information, help provide more equitable care to our patients who are in rural areas who don't have good access to care. It'll also challenge our practice of ethical medicine, and I think we'll talk a little more about that potentially during our question and answer session. Again, thank you so much to the course organizers and to everyone who's attending the webinar today.
Thank you, Professor Andreas Tom. I like that how you started your lecture from the kindergarten principles, autonomy, beneficency, and non-maleficence and justice. And particularly the word the slide that when you can open the door, better you close the door also, because he was putting on weight, and how much you have to care for the autonomy of the patient. And just because you want to have a swimming on classes along with the children, how you converted the percutaneous into the ESCP, you want to internally drain. I think you are so much caring for the patient. While caring at the same time, you have to maintain the ethical standard. When you follow the ethical standard, the legal issue is going to be less. Despite all these things, patient, because of the communication gap, or the delay in understanding, or in a work schedule we forget to really impress upon the patient what we need to we need them to know, then ethical the legal issues can come. And our advocate really pointed out where all we can go wrong in this. And I think a good combination, the platform is formed where we can go wrong, where we can take care of our patient in endoscopy. I think my colleague Dr. Ramesh, GN Ramesh, would agree with me. I invite all other panelists also to join. We have solid 35 to 40 minutes to take care of the various question and answer. So let GN Ramesh, what we usually do is you start a question, then the other three panelists are there, Dr. Neelamegam, Dr. Ramesh, other B. Ramesh, and Ashish. Everyone can ask one question to Dr. Advocate Anand and one question to. So we'll go, after finishing one round, we'll go for the another round, and I will coordinate. So Dr. G. N. Ramesh, starting with you.
Okay, I think we have a lot of questions actually, so we need to actually go. It'll be almost like a rapid fire round or whatever it is, because if we need to cover up a lot of ground. My question to you, Advocate Anand, of course, is that you did mention about in detail about consent. Now, in the consent, there is this video consent. So, which are the areas where a video consent needs to be taken?
Ramesh,
Because this
can you
is not the
unmute
usual.
yourself?
I think I'm audible.
You are audible, but this sign. Okay,
No,
okay,
no, don't
carry
worry,
on.
don't worry. I'm talking through two windows,
Okay,
so don't
right.
worry.
Okay, right.
So my question to you, sir, is that what are the indications for a video consent? Complicated procedures, I know, I understand this video consent, but what are the other? How does the law look at the requirement for video consent?
Yes, sir. Thank you. So video consent is very much permissible in law and it is acceptable in law. The only thing is video consent can be taken in areas where you have an illiterate patient and you have a difficulty in explaining and he has difficulty in understanding because it has to be explained in the vernacular language as well, which is understanding. So in cases like that, video consent will be useful.
No, the other
My
way,
sec-
what Dr. Ramesh, I want to ask is not taking video consent or be penalized. Some complicated procedures like that. That's what you want to
Absolutely.
do. Hmm.
Absolutely not. Absolutely not. A written consent is more than enough. It would suffice as far as the law is concerned. Video consent is only an additional consent to enhance our protection. But otherwise, printed or written consent is perfectly fine with the risks that are informed.
So, one more question before I then request Dr. Ashish for the next question. It is now a common practice that when we are talking to the patient's bystanders or relatives, many of them, all of them come with mobiles and they record the conversation, sometimes without our knowledge, sometimes with our knowledge. What should be our attitude or what towards this practice?
Yes, doctor, I think we should encourage that recording and also tell them that, you should also inform them that there is a CCTV and a microphone in the consultation room itself, because it's perfectly legal to have a CCTV and a microphone in the consultation room. So maybe if you encourage recording and the patient also knows that he's also being recorded, it would be more, it's easier for both sides.
So we should encourage that. That is,
Yes.
yeah. Okay.
Ramesh,
Ashish,
only thing is
Yeah.
we should be prepared for talking very legibly, very concisely, and briefly that he's recording. And use the only very selective words, and you have to be very, very careful about it. Sometimes
because uh, because
yeah,
because
while
the
you're recording.
conversation is going to go across the continents to other continents also.
Yeah,
So
yeah.
that's very important, and we need to be very careful. The idea of asking that question is what should be our attitude towards that. Dr. Ashish, for your question.
Hello, sir. So, I work in a government hospital, but so we generally do not have problems regarding treatment because of the cost involved. But sometimes we do get situations where we did a procedure after that patient had some complication, and now patients, for example, we did an ERCP where the cost was whatever would have been the cost, and the patient had post ERCP pancreatitis, and now he requires admission and further evaluation. The cost of the treatment is going. The patient starts saying that, okay, I didn't pay for the I was told for a particular cost, and now I will not pay the cost for the treatment. So what should a person do in such a scenario if the patient is not ready
Your,
to pay the amount and then he desires that the treatment should be done
your
because it's
question
your
is
responsibility?
to advocate Anand, isn't it?
I think Ramesh, both of them can take up,
Yeah.
no?
Yeah.
Yes,
Maybe,
Dr. Anand.
yeah, but Andrew may not be very well versed with the situation here, the government hospital setup that he's talking about. I think Anand, if you could answer that.
Yes,
Yeah,
yes,
sorry,
doctor.
I wanted Dr. Anand only. Sorry, I'm so sorry. Just
Yes, doctor. So here is a case where the patient refuses to pay, or rather says that he can't afford the treatment,
yeah.
but he is already in your care, and he also refuses to be referred to another hospital, I
Yeah.
assume. So in that case, it will become our responsibility to go ahead with the treatment, especially in emergent situations. If he is in a position to be discharged, then it is a different thing. But here is a case where he is already under your treatment, so we cannot refuse treatment and we need to continue the treatment.
The only problem, Mr. Anand,
What?
the cost of ERCP is X. The complication when it occurs, the hospital stay, it may become 5X. So who will bear the expenses? Even though we get a concern that there can be a complication of pancreatitis, in that case, you have to stay more in the hospital, and accordingly treatment will be given. This is a concern we take it. We don't
Yes.
explain, okay, the cost of ERCP is X, and the cost of ERCP depends on mild, moderate, severe. It may be 1 day to 10 days, 15 days. Sometimes what you have 5X, who will bear their insurance company is not having their money, they don't have the sum assured. So that is I think what Ashi is asking, very practical thing.
Yes.
So how to deal this?
If I
Yes.
could interject, you're right. I'm not up to speed with the law, but this is an opportunity for that consent. Yeah, in my opinion, and I tell all of my patients this, when I know that there is an incredibly high risk for complication, like we all face when we do ERCP, this is an opportunity for us to say during that initial conversation before the ERCP ever happens, there is a chance that you're going to get pancreatitis. 1 in 10 patients, in fact, might get pancreatitis, 1 in 10 to 1 in 20. If you get pancreatitis, it's going to result in additional, cost. And there's a chance your insurance company won't cover. I find that when I tell patients ahead of time, you're going to wake up with pain, there might be additional costs, there's additional risk. If they know that beforehand, they're much less likely to object to that issue afterwards. But I'd love to hear what others think.
Do they
So
ask
what is the
about the
difference?
cost?
So I want to ask a question to Anand.
Yeah.
What is the difference between civil negligence and criminal negligence? And when the name of the doctor can be removed from the medical register?
Yes, doctor.
Erasure of the name of the.
Yes. So civil negligence is prosecuted in a, as you know, in a civil court, which is a consumer court. Criminal negligence prosecution happens in a criminal court. Now, how do you distinguish between civil and criminal is when the negligence is gross, or if it is a higher degree of negligence. For example, you operate on the wrong leg, or you prescribe schedule X medications on the phone without looking at the patient. Our NDPS substances are, prescribed on the phone. These are of higher degree, so this will come under criminal negligence.
So when the name of the
Madam,
medical doctor will be removed from the medical register, we have
That is,
NMC.
yes. So what happens
Yeah.
is complaint, if a patient gives a complaint before the state medical council, then there is an inquiry there. There is an inquiry committee sitting there. The papers are placed before the inquiry committee. Then the doctor is called for his explanation to be
Give the
given.
evidence.
Once they take the explanation, then they decide on whether there is negligence on the part of the doctor or not. Depending on the gravity of negligence, they decide whether he can be warned and left, or if he has to be suspended for, let's say, 3 months or 6 months, or ultimately, if it is very, very severe punishment, then removal from the register will take place.
Dr. Neelamegam.
What's the consumer cost, consumer
Ramesh,
complaint
1
can
minute,
be
one by one we'll go. We'll give a chance.
Okay.
Dr. Neelamegam has asking.
So thank you, sir. Sir, basically about the video consent, I just want to add with Dr. Mr. Anand. So basically in multi-organ transplant, especially the liver transplant, we do take video consent of all the patients and also death on table. Is it necessary? And also when we have, when the patients in ICU, when they are withdrawn for a long time, we go for a multidisciplinary meeting and we do it under video consent. So these are the two instances we are thinking it implies and it is going to be logically and legally, it's going to help us. Is it good or we have to do it or is it not necessary?
Yeah, as I said, doctor, it'll be an additional support. It is good. It is an additional to whatever written consents which you take. So by all means, go ahead and do it.
But it's
Okay.
not mandatory.
It is not mandatory. What is
It is not
mandatory is
mandatory at all.
written informed consent is mandatory. This is only an additional support to it.
I do
And
wonder
another
if it
thing
makes
is,
you more suspicious as a patient, more suspicious of your care team. The only time I've ever had to do legal consent was when I was renting a motorboat, and I knew that they were doing it because they've had issues in the past, right? And I think it implies that you've had issues in the past with video consent. We never do that, and I agree with the panel. Wearable technology is a big deal. So we've had patients who've even been wearing their smartwatch and they had desaturations during their procedure, and they brought up that as an issue, as a potential legal issue. Said desaturations during their procedure. So we actually ask patients for their own safety, arguably, because we don't know how they'll interact with our medical devices, but we actually make sure that smartwatches are removed from our patients, that phones don't enter our procedural areas. I think those are precautions worth taking.
So otherwise that will add unnecessary confusion and legal issues and other things. So video consent can add more confusion, you are telling. Is it true, Dr. Andrew?
That's my opinion.
Okay.
The other thing that's becoming very popular here is to video record all operating rooms, and I think it's helpful in some instances. But if something goes wrong, if a surgeon acts badly, if you know that will count against you as well. If a nurse has an issue, it will all be there, and you'll have to include it in the medical record. So I think I would video record only if you know that you're being perfect. So if you're doing a wonderful consent that's in, very easy to understand lay language, wonderful. I think it can be helpful. But
so
also as a
basically we
patient
started.
myself, I just worry that the perception of a video recorded consent implies danger. And there's danger there, but I think the legal standard, to my understanding, is certainly a written consent. A spoken and written consent is adequate.
GNR.
Yeah, a very valid point, Dr. Andrew. I think the other thing is, of course, the fact that if a surgeon during a complicated procedure knows that it is being video recorded, it adds a little bit more stress a stress factor, and the responses may not be natural. Perfect. My question to you, Andrew, is that what is the role of consent for minors in case the parents or legal guardians are not readily available? I mean, that's a situation that is now coming up very commonly.
Yeah, and it comes up here all the time as well. I think that's another commonality across nations. If a child's health is at risk, if it's an emergency situation, I think this is another. I loved someone earlier in the conversation said there is strength in numbers. Was that Anand? I think, yeah, you said there's strength in numbers. That's absolutely true. Find, if there's not another doctor with you, find all the nurses in your practice and have them come and join you in the decision making, right? If you all decide together, this is what we must do to save this child's life, I challenge you to find a court of law that will prosecute you for doing the right thing for a child where the entire room was in agreement that that's the thing to do. That said, I would also document exhaustively your efforts to reach out to the parents, to the guardians, whoever is making medical decisions for that minor child. So if you document your wholehearted attempts to reach family, and then make a decision as a group, ideally with another a professional colleague. There's safety in numbers on those decisions. What do you guys think?
Mr.
Definitely. In fact, I'm reminded of my senior colleague, nephrologist, who always used to say that whenever you're in trouble, make noise and get more people. And on your side, get all the departments involved. Let us make noise together, and nothing can drown that noise. So
Great
I think
advice.
that is a very important.
So Anand is just smiling. So
Yes, adding to that, here what has happened is in India, they've said if it is an emergency situation and there is nobody for the child, and as Dr. Storm said, you can go ahead and treat the child. But if it is not an emergent situation, or rather you have passed the stage where it is an emergency, then any other treatment to the child, the court becomes the guardian of the incompetent child. So there we had a very sensational case called the Shenbog case, which everybody will be aware of. In that case, the court held that the court has to be the guardian of an incompetent person.
that's a very good piece of information. What's the emergency? What do you think, GNR? So,
Yes, yes, that's a
one by
very.
one
In fact,
panel is asked the other question. Then second round. Ramesh, you want to start second
Yeah.
round? Yeah.
What is the role of expert witness in the court of law?
Ah.
Yes.
If a
An expert assumes great significance in a court of law. Here, especially in the consumer court, when you say an expert, he has to be an expert in the field who has nothing to do with the present case. He should not have treated the patient. He should not be related to any of the doctors who treated the patient, or he should not even consult in the same hospital where the patient was treated. So you need to choose an expert like that. And that expert, and luckily there is a Supreme Court judgment which says the expert need not come to court. So the questions will be given to the expert through interrogatories by the court, and he can answer in writing and submit it to the court. So that assumes significance because most of the experts, find it difficult to come to court, or they're worried that they'll be cross-examined and things like that. So that is overcome, and yes, an expert evidence is very useful in court.
Dr. Arvind, you want to ask questions?
Yes, Dr. Anand, I have a question for you. You mentioned during your talk that it's always imperative and wise to have a copy of the prescription and also to have a copy of the referral letter with us. See, how judicial is this that it is admissible in the court? Because the patient can always claim that the doctor has never given me, but still he has written it now and he is producing it to the court. Do you advise us to take a signature of the patient on both the referral letter and also on the prescription whenever we issue this to them?
Absolutely, especially in the form of a referral letter. Because in many cases, the referral letter, we don't have copies at all. So, and it is your word, unless the referral letter is given by the patient to the subsequent hospital and they have documented it in their admission form, then there is a continuity of documentation. But if they do not produce the referral letter to the subsequent hospital, then there becomes an issue. It's our word against the patient's word. So it's advisable to at least take an acknowledgement when you give a referral letter to the patient.
Oh, that's very nice. Thank you.
Would it just in connection with this, now suppose I know the person to whom I'm referring to, I've issued a referral letter. Would it be also useful if I follow it up with a WhatsApp message to that doctor saying that I'm directing so and so with a referral letter? Would that be protective?
Yeah, that is a WhatsApp message is acceptable in court as secondary evidence. So as long as the other doctor responds to your message and saying, yes, I have received your referral letter.
Oh, okay. So that has to be there. Because the
Yes.
WhatsApp, the two ticks will
Is
not.
there anything like
will not be-
informed refusal, sir? As we have informed consent, do we have any informed refusal? Does it have any significance?
Informed refusal on what, doctor?
Refusal.
On what context?
No, patient, we are telling something, patient is not listening to whatever you are saying. So he goes on with, so does we have any role of this informed refusal? He's
Yes,
not
if
going
the
to sign. You are asking to sign, but he's not signing, but patient ultimately land up in some problem.
yes, see, that is
Informed
where
refusal.
when the patient refuses to sign, and if you have the patient sitting in your consultation room and you have a CCTV, that is where it assumes significance. A CCTV and microphone in your consultation room, refusal is automatically recorded.
Yeah, CCTV, okay.
It's not like informed refusal to our informed consent. So that may have evidence, the CCTV, or how about recording in your own mobile phone?
It is
Sometimes
permissible,
CCTV may not be there in the particular area we are discussing. Suppose you have a mobile phone.
that would escalate the situation if a mobile phone is suddenly taken out and you start recording what the patient is saying. It might be better to, do it in an innocuous CCTV which he doesn't see, but it's always there.
Not always there. Any such a problem you come across, Dr. Andrew?
Yeah, we'll certainly have nurses join us in the room if we have a combative or an uncooperative patient. It can be helpful to have, again, safety in numbers, to have a nurse in the room with us to serve as another essentially witness to what happens, to their disagreement or agreement. I'll say a more common and very tricky situation is the patient who consented to go ahead. Now they're on your table and maybe they're slightly sedated and they withdraw consent. Then what? So I worry, if you stop doing a procedure because they say stop, could a patient, then say, well, look, I consented to go ahead with the procedure and I was under the influence of medication. Now you've stopped the procedure. Why did you stop? And of course, you were telling them please, or they were telling you, please stop the procedure. So again, that's a situation where I think just like Dr. Ramesh had mentioned, I'll pull colleagues in the room, make noise and bring more people in, because if the nursing team is with you and your nurse agrees this patient cannot proceed safely, just document. So you write in your note the patient was not, able to move forward with their procedure. They were not adequately sedated. We had to terminate the procedure at their request and per best medical advice, which is that we couldn't safely finish the procedure. That withdrawal of consent is also something we have to think about.
Dr. GNR, you want to ask one question?
My next question is a very social question, and I would address this to Dr. Andrew first and then to Advocate Anand. In a society like ours, where a lot of people seem to be interested in what's going on with a patient, we keep getting phone calls. Sometimes it's politicians, a very close friend, about what is happening to this patient X. How is he? Could you just tell me about him? Now, I understand that patient matters are very confidential, but then we live in a society where we have so many networking networks and connections. So how do you handle that situation, Dr. Andrew, in your setup? And then I would go to Advocate Anand to get his opinion. How should we actually handle these requests? First,
Yeah,
Dr. Andrew.
I anticipate there will be some cultural differences here, but that said, we're a very multicultural hospital here. We have visitors from all over the world, and so we're very attuned to those cultural differences. I will say what we do in that situation where we anticipate either through previous experience with the family or because they give us a heads up, is we will create a list, a consented upon list from the patient. And in that situation, if the patient says, look, if my aunt, uncle, nephew, cousin, grandmother, daughter, anyone on this list who calls and wants information, they may have it. And that gives us the patient's consent then to move ahead with sharing information. We can even create different tiers of information. Like we'll tell them you're okay, or we'll tell them that you have a cholangiocarcinoma that's currently undergoing resection and liver transplant, right? We can make different levels of information they would like shared with different individuals. Here, patient autonomy and patient information protection is number one, and so we can't share it without previous consent of the patient. I anticipate there may be some cultural differences there.
Thank you, Dr. Andrew. Over to Anand, because you could probably add one more angle, that is a situation where the patient's bystanders tell us, please don't tell the patient anything about what he will not be able to tolerate this thing. So how are we expected to handle these sort of requests?
Doctor, I'll start with your second question, not telling the patient. It is mandatory under law to tell the patient as to what disease or ailment he has, regardless of the fact what the relatives say. And coming back to your earlier question, of course, there is, I understand the dynamics involved where, different kinds of people call and ask. But we need to keep in mind that confidentiality is paramount and maybe give them kind of an answer which says the patient is doing well or he's not doing well. And we've spoken to the relatives, but not divulge the actual, intricacies of the ailment that might be there. Because if suppose we give that information to somebody who's not connected and he records that and it brings it up later, then that might be an issue. So it is better to just keep it superficial and say, yes, he's doing fine. We've spoken to the relatives. It's okay.
Neelamegam?
So one question. So once a patient gives a consent for surgery, but the family refuses it, where do we stand as surgeons, sir?
As surgeons, you'll have to go ahead with the surgery because unless the patient is incompetent, and at that stage, a living will comes into play, where a living will is very much valid in India nowadays. Advanced medical directive or a medical power of attorney, as it is called. And the Supreme Court has laid down the guidelines in 2023 saying how a living will has to work. So if there is a living will, then you don't have a problem. Straight away, you follow that procedure, what the Supreme Court has said. But if there is no living will, then you'll have to go exactly by what the patient has instructed us to do.
So we don't need to follow the relatives. We can just take the consent of the patient and go ahead with the surgery.
Absolutely.
Thanks, sir.
So there was recently a case where a small surgery like cholecystectomy was done at a decent hospital, and then the patient had complications and multiple complications, and he required very invasive procedures like pancreatoscopy and placement of stent, and finally the patient died. And the ruling said that because the hospital was not equipped to manage the complications, they were fined for performing cholecystectomy. Now, cholecystectomy is a very routine surgery, can be done at medium level hospitals.
Can you avoid very personal thing? Because already
No, I just want
you can ask it as a general question because it's all being recorded internet.
So if we are not having we are doing a routine procedure,
question.
for example, ERCP we are doing, and the patient might have some complications, and then we do not have pancreatoscopy, we want to send the patient somewhere, and patient does not go there, he dies here, and then they claim that they were not capable enough to handle the complications. So the procedure should not be done. So what is your take on this thing? Like, because having everything at every center is practically not possible.
So maybe in your initial consent form, if anyway you would have mentioned about the risks of the surgery and if there is a requirement for a resurgery, you would have informed that. So if those are covered in your initial consent form, then it is taken care of, regardless of the fact, because you can't even in your initial consent, you can't think about all the risks. Might be
Yeah,
hundreds of risks with the surgery. We can't put everything
that is
down.
what. Yes, sir.
If you can just think of the major ones and put it down and cover it, saying there is a risk of resurgery or a complication, in which case, the patient, you might have to be referred to another hospital. If you have covered that, then whatever the patient says later, that will be useful
Is
for
there
your
any
report.
percentage regarding the risk of a procedure that needs to be explained to the patient? Because patient would say, okay, this was not told to me, this particular complication, which is rare, like less than 1% people have it, and then patient develops it.
Dr. Andrew clearly said 1 in out of 20 or 1 in out of 10 may get pancreatitis. You have to briefly tell them. And we have the internet on par with international standard. What is the number of complications? I think we'll move on to Dr. Girish Kumar question. Dr. Girish and Dr. Gokul, then Dr. G. N. Ramesh. And we have 9 minutes to go. Dr. Girish Kumar, Dr. Gokul, you have a question?
Yes, sir. Hi, good evening. I'm Dr. Gokul from the organizing team. I would like to thank both the speakers for the wonderful lecture. My question is to Professor Andrew Storm. So we had a patient couple of months ago who required a complex polypectomy of the ascending colon. But interestingly, she was not willing for any transfusions because we had explained the risk of blood transfusion also. She was from a particular group who refuses any form of blood transfusion. So in such a case, while explaining the risk, how to go about it? Because she may require a bleeding transfusion in case there is an inadvertent bleeding. So
Yeah,
ethically,
so
how to handle this kind of an issue?
Yeah, that comes up here actually all the time. And fortunately, we're in a resource-rich area where we can use sometimes other, blood alternatives. We can use, and I'm probably the transplant surgeons on the call can speak to this as well. If you have access to those other things, make them available. So I will call the transfusion team and say, hey, we have a patient in our country, often Jehovah's Witness, a religious group that will not accept a transfusion. And we actually have a form to document exactly what they will and will not take. So sometimes plasma is okay. Sometimes platelets are okay, but not red blood cells or not, so you would definitely want to clarify with the patient ahead of time what you might be able to use to resuscitate that patient. I would have all the tools available. Here's the thing, statistically, they're still more likely to not have bleeding than to have bleeding. So I think you put yourself in the best situation possible, document the risk and the risk of death if there's severe bleeding, which is possible, unlikely, but possible. And then this is a patient where I would do everything above and beyond. I would tell them there's going to be, okay, we won't transfuse you, but we're going to use extra clips. We're going to use, endoscopic closure to close this area as best we can, and it's gonna cost more money. But for me to be able to offer that to you and do no harm, for me to do my job well, I'm gonna have to use some additional tools, and that may mean that the procedure will cost a little more. I'm curious if others on the panel agree with that decision. But
Dr. Andrew, nothing can replace blood when you really have exsanguination. So in such cases, better to tell them and avoid or refer to some centers or where, because how many number of clips also sometimes it is exsanguination is there. I don't think anything can replace blood. That is the situation we really had what Dr. Gokul was telling. It's a very tricky situation we have to know.
That is where the importance of consent, a very, very, very detailed, ultra detailed consent is the only way. And try to get as many people involved as possible. I think that's the best way to go about
Dr.
it.
Girish, you have a
Thank you.
quick question. Thank you, Gokul.
Good question.
Raja wants to ask some question.
Okay.
Or Girish Kumar, you have a question? And before that, I just want to tell you that we had a very wonderful session. One person talking about how to avoid the legal issues, how can be very protective, and how much important the documents are so important. How 6 C's. Maybe next time when I hear, maybe 10 C's will be there. More will be added. So fantastic. Really enjoyed it. And Dr. Andrew gave a step by step how a person can swim and maintain autonomy, and how you can maintain when you close the door, and when you open the door, close the door, and a lovely session and various questions. Now we have 6 minutes for you, and this might very brief, at the same time the rapid fire questions. Rapid fire. I will start with Dr. G. N. Ramesh.
No. There's just one pressing question. Which I had to with Advocate Anand. Advocate Anand, you mentioned about post-mortem, refusal of post-mortem. My question to you is, who can refuse post-mortem? Like, that's very important. I believe that, you advise post-mortem. We usually talk to people who can absorb that whole thing emotionally, but unfortunately, they are not people who are very close to the person who has died. So, who can refuse post-mortem?
The kith and kin can refuse post-mortem, but if the kith and kin are not available and there are attenders who are not related to them, then we'll have to go by what they say.
But naturally,
Sir, I remember that.
naturally the
Sir,
patient is dead, no? So kith and kin, if not, then I had a situation long back ago. The we needed a postmortem. Then they refused it and we got it signed. A week later, somebody came. They said, why did not offer? Then I showed him this is what it is there. Well, then was very clear that I offered it a postmortem. I insisted that I would not release the body without doing the postmortem. So that is very good. That gives a lot of confidence actually that I am ready to get what I have done is right. So I am ready for the postmortem. And they refused it. I got it signed. Anyway, coming to the lighter end of the session, what is the
sir, one question.
non-medical? Yeah, what is the
Sir,
non-medical
sir,
book you have read, doctors, and what is the non-law book you have read? We'll start with the Anand, sir.
I've read Jim Corbett's Man Eaters of Kumaon. That was my
Okay, I
latest
thought you
book.
will say some medical books also. I'm glad that. Andrew, what is the non-medical book you have read?
I highly recommend The Feather Thief. It's the largest natural history theft in the world that happened in Great Britain fairly recently. He was a fly fisher. He ties flies, and he stole
Okay.
Darwin and a lot of the
This is just to
feathers from
ask
this
you
place.
that how you are relaxing. And
Yeah.
GN, you must be reading a lot of books. What non-medical book you read? GN Ramesh? Okay, while he is answering, Ashish, what non-medical book you read? Okay, unmute
TSC,
yourself.
how about you? What have you
Homo
read?
sapiens. I'm recently reading Homo sapiens by. It tells about the history of the humankind.
Okay, I am reading the history of the world. That is a very fascinating. And I have been to the museum there. Then I'm in Germany now. So I got a lot of time to read about that, how it has evolved. I really curious to know how the Darwin had really proposed the theory along with that. And I am reading another people, how to get a Nobel Prize from
Good luck.
good one. That is written by Dr. Barry Marshall. And for the kids, he has written how to train your kids to get a Nobel Prize. Very fascinating. And the Neelamegam, my ambition is very high, so maybe the reason.
Sure, sir.
Neelamegam,
Why
what
not?
book you have read? Your book? What's the book you have read? And
The
Ramesh,
latest is
huh?
the latest one I read is about chameleons, sir. One of the very good book about the animals came into Tamil Nadu.
Oh, okay, right. That's, I think you must be very proud of that. And Ramesh from Telangana, what book you have read?
No,
So he doesn't have
no
time
book.
now. Okay, the next question is, what is the famous quotation you really get inspired? Anand sir.
Quotation, there are many. One,
Famous quote. Okay, my dear, I
Yeah.
really love
Again,
this.
yeah, we can direct the wind, but we when we can't direct the wind, we can adjust our sails.
Oh, okay, that's
Oh.
fantastic. Dr. Ramesh, your quotation before I'll ask Dr. Andrew. Dr. Andrew.
Yeah, my quote is
Yes.
make a lot of noise, GN Ramesh.
What's that? Mate?
Make a lot of noise.
GN Ramesh,
Wonderful advice.
you made his day.
Yeah. In fact, then I'll go to my favorite quote, and this is inspired by what Andrew has said. The
Okay.
greatest wealth is having a healthy body, a peaceful mind, and the right people in your life. And Andrew has become one this evening.
I thought you would say that when you can open the door, close the door.
That's right.
Maybe.
That was my mother. Yeah.
Okay, Neela, what is your famous quotation? While you are thinking, Ramesh, what is your famous quotation?
Sincerity and hard work,
Okay, hard
commitment.
work is that is a work profile. Okay. What about Ashish? Unmute yourself first. Tell your
uh,
quotation.
uh,
Huh?
mine is from How to Win Friends and Influence People. It's about heartily appraisal and avoid criticism.
Avoid or face the criticism, don't react, only respond. Okay, that's a very good one. Anand sir, who is your favorite hero and heroine?
Hero, I would say Denzel Washington in Hollywood,
Uh,
and heroine there are Julia
Many.
Roberts.
Huh?
Julia
Julia
Roberts,
Roberts.
You mean the one,
Erin Brockovich,
you mean the one in the,
Pretty Woman.
Pretty Woman, Erin
Pretty
Brockovich.
Woman, Julia Roberts.
oh, Julia. Okay, right. How about Andrew?
Oh boy, I'm gonna pass on this one. I don't have a good answer.
At least you can say my dad and mom.
Yeah, for sure.
Yeah.
That's right.
GN
Mom and
Ramesh?
dad.
Huh?
Yeah.
GN Ramesh?
In the movies,
Anywhere you classify my life, my younger life,
in my
older life.
I have one role model for each area. For in the movies, if you ask me, it's Devanand. If in real life, if you ask me, it is a person called T.S. Chandrasekhar for the flair with which he does things.
Yes.
You made my day. No, I enjoyed, definitely I enjoyed. I work for this webinar and almost 38 webinars and work on the doctor-in-law and doctor ethics. It's close to my heart because getting into this kind of ethical issues and the legal issues, a major crisis. Neela, what is your, who is your hero and heroine?
Sir, I didn't get
Who is
you.
your hero and heroine?
Janvi Kapoor, sir.
Huh? Sami
Janvi
Kapoor.
Kapoor.
Oh, John
Janvi Kapoor.
Kapoor. No, hero. You don't like heroes, huh?
Hero is Rajnikant, sir.
What Ashish?
So Akshay Kumar and Katrina Kaif.
But I thought somebody would say my primary school teacher is my hero. Why we don't have to think of only the movie. This one, Ramesh.
But
Who is your hero?
don't you think it's being too philosophical when you look at my role model being my teacher or my father or mother? This is a light-hearted banter, so I thought.
Okay, right.
Yeah.
You justifying that. Okay. So what is your greatest ambition in life? Last question, Dr. Anand. So you become a doctor now, moving with all the doctors.
Yeah, I wanted to become a doctor. I didn't have enough marks, so I took up law, but it worked out well.
So you are more associate. But the way you pronounce cholecystectomy, oophorectomy, hysterectomy, and all, you are almost I thought you have become a doctor, come a lawyer.
That's because I come from a family of doctors. My mother's side all are my
Okay.
father's side all are doctors, and my mother's side are lawyers.
Okay, what is your greatest ambition, Andrew? Okay, I want this. I am the happiest man in the world.
Oh, it's funny how it changes every year, right? But right now it's to raise non-criminal children, successful non-criminal children. I don't want them to have to meet with a non.
Okay, and GNR, what is the ambition? Okay, really, I want to achieve.
Well, I have set out on a journey, and I want to achieve everything that I've set out for in the form of Rotary District Governor. I've got lots of things in mind, and I think this is something that is very close to my heart.
He has been recently elected as the Rotary Governor. I'm very proud of him. I'm also a Rotarian. What is Ashish? What is your ambition? You got everything in on earth. Now this is what I want to achieve. Okay, I'm done. And
So
the day,
possibly too, at this point of time, I can think of giving a talk at DDW would be something for that I aim at this point of time.
okay. What about Ramesh? B.
I have
Ramesh.
achieved what, yeah, I have achieved whatever I wanted, sir, as of now.
So some are contented, some are ambition to the nearest possible. Some have got a small goal. And what about Nila?
I have achieved everything, sir. Nothing much to be unturned.
Okay, okay. That means you are very contented. I think the ambition part alone, I just want to tell you a proverb that, and don't be contented in the early part of, and don't, whatever your achievement you have made it, and make them not to extinguish your fire in you. And the ambition I have is bring out the best from you, and that is useful to you, family, and the world. This is what it is. Now, I think, ladies and gentlemen, that we have come to the end of that. I know that several delegates from all over the world are watching this webinar. We had a wonderful session, irrespective of the culture, nation, and whatever the difference. The law and ethics almost same. The humanity remains the inner core of everyone. We are all here not only to avoid legal issues and abide by only law. We want to do it with the humanitarian concern. That is very important. Once you do that with the humanitarian concern, any law or any legal issues will not be really threatening us. With this, I will sign off. Thank you very much for the wonderful speakers, moderators, panelists, and I thanks for the ACG for endorsing this webinar. We will meet next month for the doctor and research grants. Thank you very much.